Thank you for joining us today for part two of our rapid fire questions about the 2026 final Medicare physician fee schedule. We hope that you enjoyed part one. In this part two session, you will learn about the key changes to HCPCS codes that address upstream drivers of health and how these changes affect practitioner reimbursement. An important takeaway message is that Medicare reimbursement is clearly shifting toward paying for whole person care, including physical activity, nutrition, behavioral health, and social support factors. This creates new reimbursement opportunities for digital health, metabolic care, behavioral health, and community-based care models. So with you today, we have Olivia Goldner from Nixon Law Group, who will be providing you with key insights regarding these upstream drivers. And I'm Mike Pappas from Nixon Law Group as well. So let's dive in. So the legal fun first. So just a quick disclaimer, you've probably seen these before. While we are lawyers, we are not your lawyers unless you've signed an engagement agreement with us. So this is informational, but certainly you're welcome to contact us if you have questions or if you'd like to learn more. So without further ado, let's jump in. All right, so question one, Olivia. What did CMS change about HCPCS code G0136, which previously reflected a social determinants of health assessment?
So, as you said, CMS repurposed G0136 so that it no longer represents a broad SDOH assessment. Instead, it now focuses specifically on evaluating physical activity and/or nutrition-related risk factors when those factors influence a patient's diagnosis or treatment plan. CMS explains that the new code is intended to identify, capture, and appropriately value the clinician work involved in administrating a validated physical activity and/or nutrition assessment tool as part of a related clinical visit. So the code can now be billed once every 6 months, but only when the assessment is tied to a medically necessary treatment plan and furnished in conjunction with an eligible visit type. These eligible visit types can include an E&M visit, a psychiatric diagnostic evaluation, or a health behavior assessment and intervention service.
All right, so moving to question number two. How did CMS update the Community Health Integration CHI code G0019?
So CMS revised G0019 to replace references to social determinants of health with the broader concept of upstream drivers of health. This terminology is intended to better reflect the full spectrum of environmental, behavioral, and structural factors that can affect treatment adherence, access to care, and health outcomes. The updated code continues to cover the key CHI activities, including contextual assessments, care coordination and navigation, culturally aligned support, communication assistance, and behavior change support. CMS noted that this framing acknowledges the connection between upstream factors and downstream clinical outcomes.
So question three, follow-up. Who could initiate CHI services?
So CMS clarified in the final rule that in addition to physicians and other eligible practitioners, such as licensed clinical social workers, marriage and family therapists and mental health counselors may initiate and bill for CHI services when those services relate to the diagnosis or treatment of a mental illness. This expansion is intended to ensure that behavioral health clinicians, who are often the ones who have the most direct insight into patient barriers and contextual factors, can fully leverage CHI services to support treatment adherence and care coordination.
Thanks, Olivia. Well, that does it for part two. Thank you for joining. Our last and final video in this series is part three, focusing on updates in the 2026 Medicare physician fee schedule as they relate to FQHCs and rural health centers. So thanks for joining today, and we hope you join us for part three.
Thank you.